Hi, I'm Christian Griffin, Deputy Director of Emergency Services for Cecil County. Treatment of septic shock is a time-critical condition for which EMS clinicians can make a significant difference in patient outcome. Timely administration of fluids and vasopressors are vital steps to stabilizing a moribund or peri-arrest patient with obvious end organ dysfunction and significant hypotension. The current Maryland medical protocols for EMS advise clinicians to attempt to stabilize their hypotensive patients using fluid boluses prior to vasopressor administration. The CLOVER study, published by the New England Journal of Medicine in 2023, compared the effects of a liberal fluid strategy, similar to that of our current protocols, with a restrictive fluid strategy in which vasopressor administration is prioritized and fluids are limited, in early treatment of patients with sepsis-induced hypotension. The results showed that both strategies led to similar patient outcomes. Based upon emerging evidence, the 2025 protocols take a more nuanced approach to patients in septic shock. You will see that, for treatment of severely hypotensive patients, vasopressors should be given concomitantly with IV fluids. For fluid-sensitive patients, we need to limit the volume of lactated ringers to avoid complications such as pulmonary edema. Starting vasopressors earlier in this fluid-sensitive population helps to improve perfusion with less risk of adverse effects. In this module, we will first look at the changes to the sepsis protocol for adults before turning to the adult shock hypoperfusion protocol and finally the epinephrine pharmacology. Note that the indications for treatment remain unchanged. The protocol applies to adult patients 18 years of age and older with a suspected source of infection and who present with at least two of the following criteria: temperature greater than 100.4 degrees Fahrenheit, 38 degrees Celsius, or less than 95.9 degrees Fahrenheit, 35.5 degrees Celsius. Heart rate greater than 100 beats per minute. Respiratory rate greater than 25 breaths per minute, or end-tidal CO2 less than or equal to 32. And hypotension with a systolic blood pressure less than 90 millimeters of mercury. Both ALS and BLS clinicians should place the patient in a position of comfort or supine if they are hypotensive. Monitor the patient's airway and respiratory status with management as required using the appropriate respiratory distress protocol and transport to the closest appropriate facility. Be sure to use the term sepsis alert in your hospital notification. Patients with suspected sepsis and either altered mental status or hypotension are considered Priority 1 patients. ALS care continues to include establishment of large bore IV access. Obtain a second IV if it will not delay transport. If IV access is unsuccessful and transport time will exceed 20 minutes, obtain IO access for Priority 1 or hypotensive septic shock patients. IV fluid administration is also unchanged. If the patient is not fluid sensitive, infuse 2 liters of lactated ringers with the IV wide open. Reassess every 500 milliliters for shortness of breath, blood pressure, and SpO2 saturation changes. Remember to accurately document the time that you started the IV fluids and the amount of fluid infused. If hypotension persists after 2 liters of lactated ringers, provide additional lactated ringers up to a maximum of 30 milliliters per kilogram. Or, if your patient is fluid sensitive, infuse 250 milliliters of lactated ringers. Carefully monitor and reassess them. If there is no worsening of respiratory status, give an additional 250 milliliters to a maximum of 500 milliliters infused. Additional fluid infusion requires a medical consultation. Fluid-sensitive patients include those with a history of congestive heart failure, pulmonary edema, or end-stage renal disease. Scrolling down to the epinephrine infusion, you will notice significant changes. For significant hypotension, meaning systolic blood pressure less than 70 millimeters of mercury, or mean arterial pressure less than 50 millimeters of mercury, and altered mental status, initiate epinephrine infusion concurrently with lactated ringers. After the epinephrine infusion is initiated, prioritize the appropriate bolus of lactated ringers and titrate down the epinephrine infusion to maintain a MAP greater than 65 millimeters of mercury or systolic blood pressure greater than 90. For persistent hypotension, systolic blood pressure less than 90, after a 30 milliliter per kilogram fluid bolus, initiate an epinephrine infusion. For fluid-sensitive patients, initiate an epinephrine infusion if they remain hypotensive with a systolic blood pressure less than 90 or MAP less than 65 after a 500 milliliter fluid bolus. Additional patient care includes monitor cardiac rhythm and perform a 12-lead EKG, but do not delay IV therapy or fluid boluses for these interventions. Obtain peripheral blood samples if time permits. Medical consultation continues to be required for additional fluid beyond 30 milliliters per kilogram or to modify the fluid dose. And if blood pressure goals are not met upon reaching the maximum epinephrine infusion rate of 2 milliliters per minute. A quick scan of the adult shock hypoperfusion protocol reveals that the changes to the sepsis protocol are mirrored here in the hypovolemic or septic shock portion of the protocol. Similarly, in the ALS pharmacology for epinephrine, the dosage instructions for hypovolemic or septic shock are: initiate an epinephrine infusion if systolic blood pressure remains less than 90 or MAP is less than 65 after an IV fluid bolus of 30 milliliters per kilogram of lactated ringers. And for significant hypotension, systolic blood pressure less than 70 or MAP less than 50, and altered mental status, initiate an epinephrine infusion concurrently with lactated ringers and titrate down the epinephrine infusion to maintain a MAP greater than 65 or systolic blood pressure greater than 90. You are treating an 85-year-old female patient who presents with a fever of 102.1 Fahrenheit and altered mental status. Her family advises that she has been sick with a urinary tract infection and a history of CHF. She has a blood pressure of 65/40, heart rate 110, respiratory rate of 22, and a pulse ox of 93% on room air. You've established a large bore IV and are administering a bolus of lactated ringers. How much fluid should you administer before reassessing for shortness of breath, blood pressure, and SpO2 saturation changes? A, 2 liters, B, 1 liter, C, 500 milliliters, or D, 250 milliliters. The correct answer is D, 250 milliliters. This patient is fluid sensitive with a history of CHF, so you should reassess after the first 250 milliliters of fluid. If there is no worsening of respiratory status, what is the maximum amount of lactated ringers that you can infuse without a medical consultation? A, 250 milliliters, B, 500 milliliters, C, 2 liters, or D, 30 milliliters per kilogram. If you chose B, 500 milliliters, you are correct. When should you initiate an epinephrine infusion for this patient? A, before administering lactated ringers, B, concurrently with the initial dose of lactated ringers, C, after the initial 250 milliliters of lactated ringers, or D, after you have administered the maximum dose of 500 milliliter lactated ringers. This patient is significantly hypotensive with altered mental status. The right answer is B, concurrently with the initial dose of lactated ringers.